Good afternoon, everybody. There are a lot of us who still do uninstrumented decompressions and uninstrumented fusions. Just to run through what is happening, well, there is a narrowing of the disc space, there's a settling down of the motion segment. Back pain is not actually the major culprit in most of these situations. It is a secondary onset back pain. What actually happens is a claudication. And most patients, as a natural history, left to themselves, if treated, would reach a situation like there, consolidate, and would end up with even a solid bony fusion without a surgery. 83% of patients with neurologic claudication do at times develop some sphincter abnormalities, and this needs to be asked for in every patient. Please remember, very often patients do not, especially ladies, share these symptoms with us, and it's very, very important to ask for vesicorectal symptoms. Stenosis, as we all know, is because of the ligamentum flavum as well as the bony osteophytes which occur. We know of the tilt that the patient takes, the shopping cart sign, because there's oxygen deprivation of the nerve roots which are coming out. Paresthesia, numbness, there's a lateral recess as well as central stenosis, both of which are adding to the symptoms. Persistent pain over a period of time, and if there is a progressive neurology under treatment, or if the patient is sharing it, that there is a recent worsening, not just of the claudication, but also of neurology, then you have to wake up, and if they share bladder bowel with you, please wake up immediately and offer them surgery. Most of them will settle down with a decompression, provided that there is no gross instability. But how long will they settle down? Well, my guess is as good as yours. Most of them do settle down for most of the times. Some of them do get unstable and may need revision or a second look. Like somebody mentioned there that he will settle only for a couple of years. Well, the first degen scoli was less than 20 degrees and should settle for many, many years at the age of 72. A few of them may not settle. If, however, they do, you have the threat of them progressing beyond with just a decompression, like Samir mentioned, and I also put my hand up, we do add a posterolateral fusion or an uninstrumented fusion in some of these patients. Does it really work? Well, I've seen a lot of them, which Dr. Chaubal has done in the past, which have worked beautifully. It's probably that we need to be more meticulous in the way we fuse them and not rely only on the implant, but on the surgical expertise that we need to follow. Instrumented fusions, yes, they do give a better chance, but we are not talking of it today. Sometimes you also do them from the front or from the rear. What protocol do we follow before a decompression? All patients are subjected to a flexion extension view. Mind you, this is not to show the instability, but there are certain situations where you'll have a fixed listhesis, which could also be just decompressed. Please remember that if there's an interbody which is almost fused, you could go ahead and stabilize them with just a posterolateral fusion, or just at times do a decompression if you've not gone too far lateral and decompress them. Go on the side which is more symptomatic. Even in claudicants, one side may be more than the other. Do a standard surgery. I'm talking of the standard decompressions. There are some of us who can do these with micro decompressions. They are brilliant. You could just go to the right L2-3 and the left L4-5 as in the previous patient. So this is what we look at today, that you would do a flexion extension X-ray. And if, like in this particular patient, there is a fixed L3-4 listhesis, I'm still going to do a pure decompression and not stabilize them. I've done a decompression at all the three levels without a fusion and left it as an uninstrumented decompression alone, because on all my flexion extension X-rays, there is no movement. I've decompressed it alone. Just a point to be made, there are patients who have severe osteoporosis, where also you may have to just decompress, because these patients don't allow implants like this, where I've attempted to put in a cage which has sunk. So be very, very sort of meticulous as far as finding out whether the T-score is less than minus 2.5 or even minus 3.5. You don't have the time to build up the BMD, go ahead and do just a decompression. Don't try to imagine instability where there isn't. In this situation, just a decompression would suffice. This patient needed only a decompression. I have not done an instrumented stabilization. And at times, do not get carried away by such telltale signs. There are people who always vouch and say that every facetal cyst or synovial cyst has to be instrumented. No, that is not the case. Some of them will, but most of them will not need an instrumented stabilization. Well, looking at the NAS criteria, there are guidelines which have been now mentioned. Does surgical decompression alone improve outcomes in the treatment of stenosis? Compared to that, decompressive surgery is suggested to improve outcomes in patients with moderate to severe symptoms. So just a decompression. Decompression alone is suggested for patients with leg prominent symptoms without instability. So those who have back pain may need a stabilization. What is the long term? 4+. Surgical treatment may be considered to provide long term, more than 4 years improvement in patients with degenerative lumbar stenosis, and has been shown to improve outcomes in a large number of patients. Thank you very much.